All right, good morning, microbiology. So, chapter 14 here, disorders of immunity. So, we've been talking about how the immune system works and how important it is that it can recognize self and non self. And when it finds that foreign invader, right, it can take it out, it can remember it. And so, what we're looking at in this chapter are disorders, times when that doesn't work properly. And so we'll look really at two main groups, hyposensitivities, what are more commonly called immunodeficiencies, right? Times when the immune system may not do that job that it's expected to. And then we'll also look at hypersensitivities. And this is where I kind of feel bad for the immune system here, right? Like the immune system is doing its job. When we're talking about allergies or certain types of so allergies are the big one, right? It's like pollen has gotten in, and of course, that's a foreign molecule and it has antigens, and so the immune system responds. But we wish it wouldn't, and so we consider that a hypersensitivity. A couple of these, it truly is, and even like a blood transfusion, right? Those are foreign blood cells. It should recognize those as non self. When we get into the autoimmunity kind of diseases, that's when it's like, okay, the immune system has gone wrong here. It has failed in its central core requirement that it is able to discern self from non-self. So that I'll give that to this chapter, right? That is the immune system gone bad. But some of these things, I think, oh, the immune system's just trying to do its job. We're just annoyed. Anyway, we're going to start out here with the hypersensitivities. And really, when we're talking about hypersensitivity, we're talking about this can be a few different things, right? It can be an excessive immune response, it could be a normal immune response, but improperly triggered. So, by pollen, for example, or it could have undesirable effects, right? So, all of those are really kind of how we're laying out that this is a hypersensitivity that we're talking about. Now, hypersensitivities fall into four categories. Type 1 hypersensitivity, you see here, is kind of that either what we would consider a common allergy and also includes anaphylaxis, so a very severe allergic reaction. Type 2 hypersensitivities, these are going to be what they're saying antibody mediated cell damage is being caused. And these antibodies are either IgG or IgM. In type 3 hypersensitivity, we get what's called an immune complex formation. And so basically, the antibodies, in this case IgG, are attacking what's considered foreign. But then that antigen antibody complex, right? So the antibody is attached. Those are settling out, say sticking in some connective tissues and things like that. And that tends to lead to inflammation and more activation of the immune system. Type 4 hypersensitivities, this is the only hypersensitivity actually that does not involve antibodies. So this is T cell mediated, and this is often referred to as a delayed hypersensitivity, and we'll look at some examples there. So, and again, you might notice, right? Type 1, IgE, type 2, IgG and IgM, and type 3, IgG. So these first three are all antibody mediated, right? And the fourth is T cell mediated. Okay, let's dive in here. So a type 1 hypersensitivity. A couple things to keep in mind here. These reactions are immediate, so they're not delayed, right? So this is to kind of put it in juxtaposition of type 4. These are immediate. When we talk about allergy, right, the technical term there is atopy. This is just a localized allergic response to something. So if, say, the pollen is in your respiratory tract, your symptoms are going to be respiratory in origin. A systemic, a body-wide type 1 hypersensitivity would be anaphylaxis. And so basically what happens here is we end up with high levels of IgE. So we'll take a look at that. So this is just giving some different examples of common allergic reactions. So this is figure 14.4. This is a little small to show in this slide. So I'm going to grab a picture here from the old book that shows us how this allergic reaction happens, right? And so here we see the allergen entering, right? Being introduced to that B cell. Notice we're showing it to a T helper cell, right? Because that's necessary to get our B cell to mature and specialize as this plasma cell. And sure enough, that plasma cell is synthesizing IgE, right? So this is your first exposure to the allergen is necessary for sensitization. So this is important to realize that, say, like the first time your kid has peanut butter and they're fine, you can't just be like, oh, they're not allergic to peanuts, right? Because it does require that first exposure to build all these antibodies, right? To build memory cells to that food source, for example. Okay. Now, what we're going to see here, right, is IgE binds to the surface of mast cells. Remember, mast cells are basically tissue embedded basophils, and they are full of these granules, they're saying, with inflammatory mediators, read histamines and cytokines. Okay, and so then any subsequent time we're exposed to this allergen, right, here the allergen is getting in again, it attaches to those antibodies that are on the mast cell, and that actually triggers what we call degranulation. So we see the mast cell actually dumping the histamine and the cytokines, right? And so we end up with things like red, itchy eyes, runny nose, sneezing, all those sorts of things, right? So really common to see in the skin, in the upper respiratory tract, in the GI tract, in the eyes, right? For some people, I mean, the severity can vary. Trying to think. You do see some GI tract involvement, so maybe we could add diarrhea to that symptom list. For some people, pain, lethargy, etc. Okay. So remember the way this works, right? So that histamine, this is just like the inflammatory response that we saw as part of the innate defenses, right? Histamine is causing us to constrict smooth muscle in the airways, right? We get bronchoconstriction, and then it has us dilate the blood vessels, right? Vasodilation. And if you recall, those blood vessels not only get larger, which increases the blood flow to an area, which could lead to things like the redness that you'd see in hives or the eyes, but it also causes those vessels to be more leaky. And that's why we see, excuse me, that's why we see fluids leaking out of the eyes or leaking out of the nose. Okay. In its more severe form, like when they're talking about hives here, this is sometimes called a wheal and flare reaction. Wheal, W-H-E-A-L, wheal and flare reaction. Hives can be quite severe. If you're seeing them over large areas of the body, that could be an indication, right, that it's no longer being a localized allergic reaction or atopy, but that we might be moving on towards something like anaphylaxis. Before we go there, let's just think a little bit about some of these allergies, right, that are pretty common. So, and again, here's showing what the dilated blood vessels, constricted bronchioles might be doing, right? So leading to things like a headache. Over on the right here, we see those, the wheal and flare. There you go. You can spell it. Diarrhea, vomiting, we see those epithelial glands all getting kind of leaky, etc. Okay, and so those hypersensitivities, right, things like hay fever, also called allergic rhinitis. This is really common in a lot of people, a lot of different airborne allergies that could target hay fever. Asthma is often triggered by some of these same particles, some of these same airborne items. What we see here in asthma, so not in this picture, but in asthma, right? Severe bronchoconstriction and really a chronic inflammation, severe overreacting to allergic chemicals. Eczema also fits under atopy, so atopic dermatitis, itchy inflammatory condition of the skin. That can be from touching something. It can also be from inhalation or ingestion of certain allergens. Food allergies, that's this picture. This is my old roommate, and she is allergic to sunflower seeds. So that can affect the GI tract, the respiratory tract, or the skin. You might see vomiting, diarrhea, abdominal pain, eczema, hives, rhinitis, asthma, you name it, right, to something like a food allergy. You don't know her, so it's a little tough to tell, but her eyes are swollen, they're leaking, her nose is all inflamed, her lips are swollen. And typically it's not great when you start seeing the airways swelling. And in fact, she went to the ER after this reaction. So she carries an EpiPen and tries to avoid sunflowers. Drug allergies are also very common, right? So the number one would be penicillin, which is one of our antibiotics, but some people are also allergic to aspirin, opiates, the contrast dyes that maybe you use in something like a CT scan. And those can also pass through food to the allergic individual. So if a farm animal, say, is given antibiotics or something like that, that can affect a highly allergic person. So anaphylaxis. So my roommate here is moving towards having an anaphylactic reaction. Oh, sorry. This is this is more than just food allergies. This is just allergies in general. So anaphylaxis. Keep in mind what we're looking at in anaphylaxis is a systemic response, right? So primarily the respiratory system and the circulatory system are being affected here. And so you see that really in all these examples, right? The constricted bronchioles, that would make it more difficult to breathe. And then dilated blood vessels, right? And so what you're seeing happen is if enough blood vessels dilate, essentially the blood pressure drops, right? You have the same blood volume, but it's in a larger space. And so the blood pressure drops. And we're going to have a hard time actually getting blood to those important organs. And that's called shock. So when we talk about anaphylactic shock, it's this drop in blood pressure leading to shock, but it's caused by this allergic reaction. Right, so this could obviously be considered a overreaction of the immune system because the concentration of those chemical mediators, things like histamines and cytokines, and the strength of that response are greatly amplified. Right, they far outweigh the necessary reaction, say, to deal with a foreign antigen. So often these type 1 hypersensitivities, these allergies, are diagnosed by skin testing. And so here we see, I believe that's a patient's arm, and they've put slight injections of lots of different potential allergens. And we're looking for that swelling, for that reaction, for the immune system to be coming after this. And notice, I mean, so many different things, right? I mean, lint, dander, dust in the house, tobacco dust, housefly, right? Mites, those might show up in your bedding, mosquitoes, various mold spores, etc. Okay. And so what we can do here, right, if we think about treatment-wise, we have a couple different options. So obviously, trying to avoid the allergen. So they're saying, particularly things like drug allergies are often noted. We might be doing things to try to block the events in the allergy, right? So things like steroids, Steroid drugs kind of calm the immune system or suppress the immune system. And so we could slow down the production of IgE that's necessary to trigger this. We can actually give people antibodies that attack those IgE antibodies, right? See, the maroon ones are kind of our own. And then these monoclonal antibodies made in the lab, can actually attack IgE for that specific allergen. There's a drug called cromolyn, and that actually prevents mast cell degranulation, so that can kind of limit the response. And then things like the really common drugs, things like antihistamines, those are able to block some of those chemical messengers. So in this case, something like histamine. Epinephrine can counteract anaphylaxis. Basically, epinephrine causes vasoconstriction and bronchodilation. So we're trying to reverse what's going on in anaphylaxis. Desensitization. This is actually super cool, but also kind of confusing. So desensitization is a process where you would be going to an allergy specialist, to a doctor, and often this can be monthly, particularly when you're starting out. And what you're getting are controlled injections of those specific allergens, right? The things that you have reacted to. Now, this is where understanding the immune system is the only thing that makes this possible. Look at this. So what we do by getting these small doses of the specific allergen is we're actually stimulating the body to produce IgG, not IgE. IgE is the one that stimulates mast cells, but we're going to create IgE antibodies that take out the allergen. So notice now, right, those allergens are basically all grabbed and neutralized, taken out of circulation, and we don't have the allergen to trigger the IgE on mast cells. This is so clever to me, right? So the IgE antibodies remove the antigen before the IgE can react, right? And this is super effective in a lot of people. So often a result of desensitization, we'll see that there's no increase in IgE during allergy season, a decrease in that mast cell reactivity, decreased lymphocyte reactivity to allergens. So it's kind of counterintuitive, right? Often, allergies worsen with exposure. Scientists working, say, with lab rats day in, day out will often develop an allergy because they keep getting dosed by these mice. But something about giving these small doses and slightly slowly increasing them over time is what kind of shifts what kind of antibody is made. So very cool. Okay, so you have to tell me in class, what is this? What are they trying to show? I can't decide if it's a baked potato or a loaf of bread, and I have no idea what it has to do with desensitization. So maybe you eat small doses of that. You put it in your bread. I don't know. You tell me. Wrong way. Okay. Type 2 hypersensitivity. Okay. So in this case, we're looking at kind of I guess the way I would describe it, or the book would describe it, is a complement-assisted destruction of cells by antibodies, right? So remember complement, putting in those membrane attack complexes? Here, we're seeing them actually destroy or lyse cells that the antibodies IgG and IgM have attached to. So the really classic example here is going to be a blood type incompatibility. Again, this is not the immune system's response. The immune system's fault, right? We're saying, hey, we had, a type A donor and we gave it to someone with type B blood. Of course their immune system reacted, right? But what this looks like is the binding of an antibody. So here's the antibody against antigen A, right? And this is going to bind to the foreign blood that's brought into the body. This makes perfect sense in this case where we have the improper blood type, right? And we talk about that more in anatomy, so we won't go into blood typing here, but you do have to be careful there. Maybe this, to me, this is a better example. So this is also a type 2 hypersensitivity. This is hemolytic disease of the newborn. And so this is actually going to be when mom and baby have different blood types, specifically different Rh factors. The Rh factor is going to be an antigen on the surface of blood cells that gives you either a type, like a positive blood type or a negative blood type, right? Is the presence or absence of that. This only happens in an Rh negative mom when she has an Rh positive baby. So what we see happening here, right, is that when Rh negative mom becomes pregnant with her first Rh positive baby, right, what we're going to see is that some of those blood cells actually cross, or I shouldn't say blood cells, but some of those antigens actually do cross the placenta. So the Rh factor in baby, that's those little triangles here, is crossing the placenta and entering mom. And particularly during delivery, this is very common, right? And so mom's immune system says, wait, what is this foreign antigen? And starts developing antibodies against the Rh factor. She doesn't have the Rh factor, right? She's Rh negative, and now she's been sensitized. Okay. And so what really ends up being problematic is during the second pregnancy with that Rh positive baby, notice her antibodies are starting to cross the placenta and actually attack the newborn. And so this is quite problematic. This baby is jaundiced, and it can be worse than that. So this one's really cool. They came up with a treatment, and this treatment is called RhoGAM. And basically what mom gets, and she needs this during her first pregnancy, is she is going to get injected with antibodies against the Rh factor. And again, this is kind of counterintuitive, but what happens is, since there's only a few, particularly in that first pregnancy, a few of those antigens moving into her body, if the RhoGAM can find them and grab them, right, then her immune system is never sensitized. And so the only thing I don't like in this picture is like they're showing those green antibodies, like she's like the ones she was making. Basically, she won't make the antibodies because the RhoGAM is keeping her immune system from ever seeing the Rh factor. Anyway, super clever. We can talk about that more. More blood typing. So again, type 2 hypersensitivity, right? That is really what we're looking at is blood type incompatibility. Okay, type 3 hypersensitivity, a failure to remove antigen antibody complexes. Right? So normally what should happen, so there's a nice like a contact dermatitis sort of situation here. So normally what should go on, right? Here's all our little antigens, right? And we see our antibodies attaching to them. And notice what's happening here is they're building up in the basement membrane. So here's epithelial tissue. This would actually be facing the airway, facing the inside of a blood vessel, but underlying that epithelial tissue is a basement membrane. It's just connective tissue. And so these antigen antibody complexes are lodging in there, and they should be getting removed by neutrophils. But this is a failure, right, of that immune and phagocytic system to remove these complexes, right? And so this is going to lead to kind of, I guess, chronic inflammation, right? Inflammation and complement activation. So a couple different examples. So here they're showing this can be a problem in the kidney. So remember, the kidney is our filter of blood. You could get a kidney type 3 hypersensitivity. This is not uncommon following something like a strep infection. for whatever reason, those immune system complexes, right, the antigen and antibody from the strep, can get deposited in the blood vessels inside of the kidney. And so we'll see kind of this inflammation and often scarring of something like the kidney. Lupus, this is a autoimmune disease where you actually produce antibodies against essentially DNA. They say nuclear antigens, essentially against your DNA. And those antigen antibody complexes, again, deposit in collagen rich tissues, so places like the dermis. And so you're going to have kind of a reddening or a rash because of that inflammation. Okay. Again, maybe even better picture here. Here's that antigen antibody complex. It's being attached to that basement membrane. The neutrophils are coming and trying to get rid of it. They're failing. And kind of as a friendly fire, we see tissues surrounding that being destroyed. Type 4 hypersensitivity is going to also be called a delayed hypersensitivity. And so this can actually be several days that this reaction is involved. And again, just a reminder, there is no antibody involvement. This is the only one, no antibody involvement, but the T cells are involved. Okay, so our examples here, things like contact, I said that for type 3. That was not, that was just a redness or a rash. Sorry. Contact dermatitis is a type 4 hypersensitivity. The other thing that fits under here is also graft rejection. So if you get a kidney transplant or something like that and the body rejects it, that is considered a type 4 hypersensitivity. Again, it's really not the body's fault. Like if you have someone else's kidney, I get it. The immune system is just trying to do its job. But that's a problem for us. So the way, here we go. So something like poison ivy is a contact dermatitis. And what happens here is that you get the oils from something like that poison ivy plant on the skin surface. And it crosses the skin. It's taken in by this dendritic cell, essentially macrophage, in the skin. It's processed and held on the surface, right? This is an antigen presenting cell. And so here we see that helper T cell that recognizes that antigen starting to activate things like macrophages and cytotoxic T cells. And so the macrophages are coming to the skin surface. They're looking for that antigen as well. The cytotoxic T cells will actually kill the cells where it can find this same antigen. And so you have all these enzymes, inflammatory cytokines, and that kind of characteristic damage to the skin, the blistering. Now, as far as a graft rejection, basically what's going to happen there, so host versus graft, graft versus host. Okay, the more common here is host versus graft. So notice what happens here. This is our transplanted kidney, and if we kind of zoom in there, right, what's happening is the host, your own cytotoxic T cell, ends up recognizing the foreign antigen, right? This is a foreign kidney. The kidney, just like every other cell in the body, has those MHC1 proteins holding out samples of its own proteins. The cytotoxic T cell recognizes it, right? And then we're going to start attacking that graft, right? That transplant. Now, less commonly, occasionally, the graft can actually reject the host. And this really only works if you're looking at a bone marrow transplant. So here we have bone marrow has been grafted into you, right, into self. And what's going to end up happening is these new lymphocytes that are put out there, right, they are technically the foreigner. But as they start to go around the body, they might recognize some of your own cells as foreign, right? Because they were used to someone else's liver, and now they're like, wait, what is this protein, right, on the surface? And so that's kind of an interesting example of where, if you don't match bone marrow carefully, you could actually give someone an immune system that starts attacking that host. A little bit of terminology when you think about grafts. Wow, isograft, identical twins. That's probably not too often. Autograft. So this would be when you donate tissue to yourself. So an ACL repair is a pretty classic example. So taking a piece of the patellar tendon or the tendon off the hamstring or something like that. That would be an autograft. The nice thing about these two is autograft, it's yourself. You're not going to reject that, right? And isograft, if you're identical twins, it should basically be the same, right? Your immune system should just recognize that as self. Allograft is when you take that transplant from someone else. So someone donates a kidney to you. Of course, there is a risk of rejection there. Also under allograft, since we were talking about ACLs, you can actually get a cadaver ACL. That would be an allograft. The nice thing with tendon, since it's connective tissue, there's very few cells. It's more just connective tissue, collagen. And so that would have a very low risk of rejection. And then we're also doing some xenograft, grafting actually from other species. And so pigs are very closely related, and so we can use things like their heart valves to replace our own, but of course, always a risk of rejection. So anytime that tissue transplant is being considered, it's more than just a blood test to match a donor, right, to the recipient. You actually have to do tissue typing, looking at the MHC, the major histocompatibility complex proteins, making sure those antigens match as closely as possible. Okay, so that is it. That's just one more picture of a type 4 hypersensitivity. Okay, and there's poison ivy. Okay, autoimmunity. So in autoimmunity, basically, this is a time where you really can say, okay, the immune system has messed up, right? It is now recognizing self as foreign and trying to decide it, to destroy it. So this is essentially a hypersensitivity to our own cells, right? We produce autoantibodies, antibodies against self. And so this is not good. A lot of these autoimmunities are either type 2 or type 3 hypersensitivities. So here's some examples: lupus, rheumatoid arthritis, and so you can kind of see those classes. Type 2, type 3 are really common. There's also some type 4 hypersensitivity. There does seem to be a genetic susceptibility. There may be a couple, but for the most part, we have not identified specific genes where you could say, oh, my parent has this autoimmunity, am I going to develop it? One of the things we absolutely know is that females have the majority of autoimmune disorders, right? So some cases of genetic susceptibility, absolutely females are the majority of patients. Otherwise, there's a lot of unknowns as to how these autoimmune diseases originate. Okay. So this is looking like lupus. You get this kind of rash on your face, rheumatoid arthritis, a severe inflammation, kind of disfiguring of the fingers. And basically this is trying to show us what an autoimmune disease looks like. And this is a particular autoimmune disease called myasthenia gravis. And what happens here is a lot of you will recognize this maybe from A&P, right? Where the nervous system is releasing a neurotransmitter called acetylcholine that needs to dock on skeletal muscle to signal contraction. In myasthenia gravis, you actually produce an autoantibody that basically attaches to that receptor, right? So it ends up acting right? It recognizes this receptor protein as foreign and it's attaching to it and basically acting as like competitive inhibition. That's going to keep the acetylcholine from binding and those muscles end up getting paralyzed. So usually this shows up first in the eyes. The eyes will kind of start drooping. The patient's having trouble opening their eyes. Let's talk in class a little bit about some of the other theories for why autoimmunities develop, what causes them, because there's some really interesting research being done there. Okay, last but not least then, immunodeficiencies. So basically immunodeficiencies fall into two categories. Primary immunodeficiencies, these are congenital. You're born with them. They're genetic in origin. Secondary immunodeficiencies are ones that are acquired. So this could be the result of another disease like HIV, or it could be a result of, say, a treatment. Chemo, maybe being put on corticosteroids, right? Different immunosuppressive drugs. And they would also say things like stress, nutrition, aging, those would all be causes of secondary or acquired immunodeficiency. So when we look at, I guess this shows us, when we look at primary deficiencies, right, these can be kind of generalized. So there is a primary immunodeficiency. Where's my picture? A primary immunodeficiency, this is the boy in the bubble, where he had a disorder called severe combined immunodeficiency, SCID. And this is a generalized dysfunction. He basically doesn't produce B or T cells. This person is without an immune system. But there are also lots of other kind of more nuanced primary immunodeficiencies. So, for example, DiGeorge syndrome. This is a thymus defect where, like, the thymus is not matured enough, or is not functional. And so the thymus is where T cells should develop, right? So here we see a pre-T cell going to the thymus. DiGeorge syndrome would mean that that patient is going to have a T cell deficiency. We might see other patients with some B cell deficiencies. Maybe they don't make certain classes of antibodies, right? So there's selective IgA deficiency. These individuals, their T cells all work and most of their B cells work. They can make IgG, they make IgM, but they do not make IgA. And IgA is the antibody that typically coats the upper respiratory tract. And so these individuals are going to be at higher risk of developing respiratory tract infections, right? So you can either have this total lack of an immune system, or we'll see a few different examples of where certain portions of the immune system are deficient. Again, secondary immunodeficiency, we're looking at acquired immunodeficiency. So AIDS, acquired immunodeficiency syndrome, this is caused by the human immunodeficiency virus, which goes after helper T cells. And so this limits your immune system's ability to respond. Other secondary deficiencies, things like cancers in the bone marrow or different lymph organs, can lead to an immune system that's not functioning properly. And again, stress, nutrition, chemo, corticosteroids, anti-rejection drugs, if you got that transplant, right? So you're trying to prevent a type 4 hypersensitivity in your kidney transplant recipient, right? You don't want them to reject that. And so then you need to give them drugs that suppress their immune system. They're more likely to catch pneumonia. So it's not perfect, but the immune system, again, I kind of feel bad for the immune system, like dragging up all this junk, because most of the time the immune system does an amazing job. It's actually a really hard job, as we saw back in chapter 13, how nuanced it has to be. And so, yeah, sometimes it makes some mistakes, but it's kind of the trade-off that we make for having an immune system that works most of the time. All right, we'll see you in class.